Hello friends, let us now discuss the diseases of external ear. So we have already discussed the embryology. Let us first start with the diseases of the embryology, then we'll go to the other diseases. Okay, so remember we have discussed the different branchial or the pharyngeal arches. We have also discussed the different clefts in the pouches. Okay, so first cleft, near the first cleft the arch goes inside and forms the EAC. We also know about the pouches and the derivatives of each of these pouches. Okay, now before we go over there, now remember what happens to this second, third and fourth cleft. So you see, the second arch, it grows down. So it grows down and it covers the second, third and fourth cleft. Okay, and therefore these clefts, they get obliterated later on and they disappear. So I told you in the embryology that no structure develops from the second, third and fourth cleft. Okay, so we discussed this, that no structure develops from second, third and fourth cleft. Only near the first cleft the arch goes inside and forms the EAC. So the EAC forms from the first arch itself. Okay, now however, sometimes you see these clefts may not disappear. The second, third or the fourth cleft may not disappear and the epithelium may remain inside, leading to formation of a branchial sinus. Okay, so what is a sinus? First of all, what's a sinus? Sinus is a epithelium lined blind ending tract. Okay, so that is a sinus. So that means this sinus has only one opening, right? So you can see over here the branchial sinus, it has only one opening. The most common branchial sinus, it forms from the second cleft, right? The most common is the second branchial sinus, brachial cleft sinus, and this sinus has an opening over here, that is the anterior border of SCM. Okay, so this opening is in the anterior border of SCM, upper 2/3, lower 1/3 junction. Okay, so upper 2/3 and lower 1/3 junction, that is the place where we have the opening of the branchial sinus. Now what is the problem with this branchial sinus? You see, this is an epithelium lined tract, and the epithelium has a property that it grows from the basement membrane, and the dead epithelium is shed off. So what will happen? The dead epithelium is shed off and this dead epithelium will come out as a whitish discharge. Now this epithelium, the dead tissue, is a very good place for the bacteria, for the infection to grow. Okay, so what will happen? The bacteria will come and grow over here, it will go inside and now it will form pus. So sometimes there can be pus, there can be an abscess formation in these abnormal openings, the branchial sinus. Okay, right. Now sometimes you see this branchial sinus can have an internal opening. Okay, now it can have an internal opening. Now where will be the internal opening? Remember, the most common external opening is by the second branchial cleft. Okay, so that's known as branchial sinus, right? Now if it has an internal opening, now there are two openings, external as well as internal opening, that is known as fistula. So what is fistula? Fistula is a epithelium lined tract having how many openings? Two openings. Okay, so it connects one cavity to another, right? Or it connects a cavity to outside, like in this case, right? So it has how many openings? Two openings. Now the most common branchial fistula is the second branchial fistula. That means it develops from the second branchial cleft. Okay, so that's the second branchial fistula. And now where will be the openings for this second branchial fistula? So once again, the external opening will be at the same place, that is the anterior border of the SCM, upper 2/3, lower 1/3 junction. Where is the internal opening? The internal opening, remember, the palatine tonsil develop from the second pouch. Okay, so the internal opening is in the tonsillar fossa. All right, the internal opening is in the tonsillar fossa. If somebody asks you more specific, it is generally in the posterior tonsillar pillar. Right? So the internal opening is the posterior tonsillar pillar. Okay. Now, what is the problem with bronchial sinus and fistula? As I told you, these are epithelium lined tract. So some abnormal whitish discharge will come out because of the dead epithelium. And this is a good place for the bacteria, for the infection to grow. Okay. So there can be formation of abscess, neck abscess over here in these places. Okay, that can cause a lot of pain, fever, other problems to the patient. So the treatment for the bronchial sinus or the bronchial fistula is excision. You have to surgically excise the bronchial sinus or the bronchial fistula. Okay, now before the excision, before we go to treatment, now let's look over here. How will you confirm your diagnosis of bronchial sinus or fistula? So you confirm the diagnosis of the bronchial sinus or the fistula with the help of a sinogram, right? So what you do is the patient comes to you, you inject the dye in the external opening. So as you can see over here, we are injecting the dye in the external opening over here. So we are ordered for a sinogram. Okay. Now, when the dye was being injected in this patient, in this particular patient, what do we see? That this dye keeps on going up, right? It keeps on going up, right? And then in the next we saw that the dye is coming from the pharynx and then into the esophagus. So you see, this we ordered as a sinogram, but because there was internal opening, it has not remained a sinogram. Now we know it is actually a fistula, and this investigation has therefore become a fistulogram. Okay, so I ordered a sinogram because I could see only one opening. I cannot see the internal opening. All right, so I ordered a sinogram. It has automatically become a fistulogram. All right, so this is the investigation of choice, a sinogram or a fistulogram, to identify the bronchial sinus or the bronchial fistula. Okay, now the treatment for the bronchial sinus or the bronchial fistula is surgical excision. Okay, now remember, the most common bronchial fistula is the second bronchial fistula. External opening, I told you, is at the border, anterior border of a CM, upper 2/3, lower 1/3 junction. So what do we do over here? We over here give a straight incision. Okay, we give a transverse incision over here. That will be a skin crease incision, right? So bronchial fistula, you will give a skin crease incision, right? So bronchial fistula, what we do is we give over here a skin crease incision. So suppose this is the SCM and we over here have the fistula. So what we do is we give a skin crease incision over here and we take out this fistula. Okay, so now we know that this fistula is going up, right? So we start tracing the tract of this fistula and we start taking out the whole tract. But as soon as this fistula, it crosses the level of hyoid bone. Okay, as soon as it crosses the level of hyoid bone, this fistula takes a turn. Right? So this fistula takes a turn and then it starts going inside towards the tonsillar fossa. All right. So you give one incision over here and then you give a second incision over here. All right. Now when it takes a turn after the hyoid bone, it will go between the ICA and the ECA. Okay. So it goes between the internal carotid artery and the external carotid artery. Okay, so now you give a second incision over here for better visualization and then you trace this fistula between these arteries till the tonsillar fossa. All right, so remember two things. Number one, this type of incision, this is known as step ladder incision. Okay, so we give two incisions. This is known as step ladder incision. All right, and now second thing, important thing, that this bronchial fistula is going between the internal and the external carotid artery. So the surgeon has to be very careful because these two are the great vascular structures in the neck and damage of any of these structures is catastrophic. All right, so we have to go between these to take out the whole fistulous tract. Okay, now that was the second branchial fistula. Sometimes a question is asked, the third branchial fistula, where is the internal opening for the third branchial fistula? And answer is pyriform sinus. So pyriform sinus or pyriform fossa. So this we will be studying in the pharynx, okay, in the hypopharynx. We will be studying the pyriform fossa or the pyriform sinus. Right, so the third branchial fistula opens in the pyriform fossa. So now let us come to preauricular sinus. So what is a preauricular sinus? So you see over here, the sinus, it means one opening. Okay, so we know that sinus is the one opening. Preauricular, so anterior to pinna. So you can see over here, there is an opening anterior to the pinna. Where is this opening? This opening is just above the tragus, okay, or you can see it is just anterior to the anterior turn of the helix. So remember, what do we have over here? We over here have a line. What is the name of this line? The name of this line is incisura terminalis. Okay, and what is this line? This is the plane of fusion of first and second arches. Right, so remember, preauricular sinus, this is a defect of fusion of hillocks of His. So we know that the hillocks of His, they fuse over here, right, the first and second arches. So this is the defect of fusion of first and second arches, or you can say defect of fusion of hillocks of His, right. So that is a preauricular sinus. Again the same problem, there is a epithelium line tract, it can get infected, patient can have abscess formation. Treatment, the treatment is surgical excision. Okay, now the point to remember over here is that this preauricular sinus, at some point it may be adherent to the cartilage. Okay, to the pinna cartilage it may be adherent, so we may have to remove a part of the cartilage also, because it's a defect of hillocks of His. Hillocks of His, they form the pinna, right. Okay, now the next is the collo-oral fistula. Okay, so we can see over here, this is a collo-oral fistula. Fistula means having two openings, right. Collo-oral, so we have the collar and we have the oral. Oral means the ear, and the collar, the shirt collar. So between the shirt collar and the oral, between the pinna and the collar, we have the fistula over here, that's known as collo-oral fistula, right. Okay, so you can also say that this fistula is between the angle of mandible and the anterior border of SCM, right. So angle of mandible, behind the angle of mandible and anterior to the anterior border of SCM, sternocleidomastoid muscle, we have this fistula. Okay, now what is this fistula? This fistula is a defect of first cleft, right. It's a defect of first cleft. So if the first cleft does not close down completely, we have a collo-oral fistula. Okay, now where this will be the opening? So we have seen the external opening, the internal opening. Okay, the internal opening is in the floor of EAC. The internal opening for this is in the floor of EAC. Okay, so what is the treatment for collo-oral fistula? So treatment for collo-oral fistula is also surgical excision. But what precaution you have to take over here? You see, this fistula, it goes near the facial nerve. Okay, sometimes it may be even adherent to facial nerve, especially if the patient already had a abscess formation, so there is some fibrosis and it may be adherent to facial nerve, so therefore facial nerve is likely to be damaged. When you do the surgical excision, you may damage the facial nerve, especially if it is adherent to the fistula. Okay, so you have to take a lot of care while doing the surgery. We know that the facial nerve over here goes to the parotid gland. So sometimes we may even have to do superficial periodectomy, dissect out the facial nerve, separate the fistula from the facial nerve, and then remove the fistula completely. Okay, so also remember, if there is a preauricular sinus, if there is a patient with preauricular sinus, now this patient does not have any abscess formation. He comes to you at the age of 2-3 years. There is no history of abscess formation. There is no history of any problem with the sinus. So what will you advise the patient? You will advise the patient that there is nothing to do right now. When the patient grows up, the patient becomes an adult patient, okay, then you may remove a preauricular sinus because it is not causing any problem. On the other hand, colloidal fistula is very near to facial nerve. So if there is infection at any point of time, it can damage the facial nerve. The abscess can cause facial nerve palsy. Plus, the abscess can cause fibrosis. And now the facial nerve will be adherent to colloidal fistula. So if you do a surgery after that, it will be very difficult for you to remove the fistula without damaging the facial nerve. Therefore, you would not like to give a chance for this fistula to get infection. What I want to say is you would like to remove it as soon as possible, even before it gets any infection. Whereas preauricular sinus, if there is no infection, there is no abscess, you can wait as much as the patient wants, okay. Sometimes you can wait even till the adult time when the patient gains 18 years of age, because at that time you can even operate a preauricular sinus under local anesthesia. All right, okay, so that's how we decide which fistula, which sinus we have to remove when. Okay, so then we come to the next congenital anomaly of the pinna, and that is known as bat ear. Bat ear is the most common congenital anomaly of the pinna. What happens in this? In this, there is an extra prominence or lateral prominence of the pinna. That's because of absence of the antihelix. Okay, and because of this absence of antihelix, the concha size also increases, and there is a lateral protrusion of these pinna. Okay, a very severe variety of bat ear is also known as lop ear, right? Okay, how do we treat this? We treat it by doing otoplasty. So what is done in otoplasty? In otoplasty, we give an incision behind on the pinna and we remove a part of the cartilage and then we stitch it back. Okay, so that will take as a lateral protrusion as well as it will form a antihelix on the pinna. Okay, so this surgery is known as otoplasty, where we improve the shape of the pinna. Okay, now let's come to the next condition known as anoxia or microtia. Anoxia means complete absence of pinna. So you can see there is no pinna. Microtia means a small or a rudimentary pinna. Now again, these are defects of fusion of these hillocks of His, right? The first and second arch form the hillock of His. Now, how will you treat a patient of anoxia or microtia? So what is the problem with this patient? The problem is cosmetic, right? So how will you treat? You have to make a new pinna. So that is known as pinnaplasty, right? You have to make a new pinna. So what do you need to make a new pinna? You need two things. Number one, you need skin. So skin you can take from the surrounding. Okay. Number two, you need cartilage. Remember, the pinna is made up of cartilage. The cartilage is harvested from the ribs, costal cartilage. Okay. So we can harvest the cartilage from the ribs, costal cartilage. But the costal cartilage, the rib cartilage, it develops by 4 to 5 years of age. So that means you have to wait at least till 5 years for complete development of the ribs cartilage, so you can harvest some and form a pinna. Okay, so that means pinnaplasty is done between the age of 5 to 7 years. Okay, so remember, pinnaplasty is done at the age of 5 to 7 years. Why? Because we need the rib, the costal cartilage to develop. Okay, next we come to EAC atresia. Absence of EAC. So you can see over here, no EAC. Now this is a defect of first arch. Remember, the EAC is formed by the first arch. So the EAC atresia, that is a defect of first arch. Okay, now how will you treat this EAC atresia? You will do a canaloplasty. So you will do a canaloplasty and you will form a new EAC, a new canal. Okay, now let's say there is a patient who has anoxia. Okay, that means there is no pinna and there is no EAC, there is EAC atresia. Okay, so this patient comes to you, on one side there is unilateral anoxia with EAC atresia. Now what will you do for this patient? Okay, now remember, these patients, when they present to us, they usually have only one problem. You see, the other side is normal. So other side pinna, the EAC is normal, patient hearing is also normal. So patient is able to hear everything. All right, his main problem will be a cosmetic problem. Okay, so usually these patients have cosmetic problem. So what will you do? You will repair only the pinna. Okay, so you may repair only the pinna. So that means you do a pinnaplasty. After this, if the patient wants, you can even do canaloplasty. But remember, there is a rule. What is the rule? We always do pinnaplasty before canaloplasty. Why? Because if you give an incision for canaloplasty, if you try to do canaloplasty before pinnaplasty, you give an incision for canaloplasty and you cut the skin and you make a canal. Now later on when you try to do pinnaplasty, you will have scar everywhere. Okay, and therefore you cannot harvest the skin for pinnaplasty. So the pinnaplasty result will be very poor. Therefore, pinnaplasty is always done before canaloplasty. Okay, that's a rule. Now let's say we have a patient. This patient has bilateral anosia with EAC atresia. Okay, patient has bilateral anosia with EAC atresia. Now what will you do? See, now the patient has two problems. Which two problems? Not only patient has cosmetic problem, but the patient also has hearing problem. Okay, so what will you do? You see, we cannot do canaloplasty before pinnaplasty. So that means we have to do pinnaplasty first. But the problem is that for pinnaplasty, we have to wait for at least 5 years of age. Okay, we cannot do canaloplasty before pinnaplasty, but for pinnaplasty, we have to wait for at least 5 years. So what will you do? What will you do for hearing in these patients? Because only once you will repair the pinna, you will form a new pinna, then you can do a canaloplasty. So how will you give hearing to these patients? For giving hearing for these patients, we have a solution that is known as bone anchored hearing aid, BAHA, bone anchored hearing aid. This hearing aid consists of a titanium screw. You see, this is the titanium screw. Now, this titanium screw is implanted in the skull. So, implanted in the skull behind the pinna, okay, or behind the place where there will be a pinna, you can implant this screw. Now, this titanium, the titanium metal, it has a unique property. That property is known as osseointegration. So that means within a few weeks, or let's say 3 months time, it will become a part of this bone. It will integrate completely with the bone. So that's a property with titanium, unique with titanium, osseointegration. So now once it integrates with the bone, once it becomes a part of the bone, so now what will you do? You will put a hearing aid over here. Okay, so you'll put an abutment and on that you will attach a hearing aid. Now this is a special hearing aid known as bone anchored hearing aid, BAHA. What is the advantage of this hearing aid? This hearing aid, it will take the sound, it will convert the sound into vibration and will give it to the screw. So now the screw will vibrate and the vibration will go to the bone because it is integrated with the bone, and the bone will take the vibration directly to the inner ear. So the bone takes the vibration directly to the inner ear. Okay, so patient is able to hear. You have bypassed both the external ear and the middle ear. This is known as BAHA, bone anchored hearing aid. I have just told you the indication for BAHA. The indication was BAHA was bilateral anosia with EAC atresia. You need not do it in unilateral. You may have to do it only in bilateral anosia with EAC atresia. Okay, right? So that is your BAHA. But there is one problem with the BAHA. What is the problem with the BAHA? You see, this screw has to be implanted in the skull bone. Okay, for implanting in the skull bone, you need at least 2.5 to 3 millimeter thickness. Okay, this much thickness of the skull bone, this skull bone, this much thickness is required. Otherwise, this can puncture the dura. It can go inside, it can puncture the dura. Patient may even have CSF leak. So it will damage the brain, okay, if the skull bone thickness is less. So generally, the child achieves this thickness by 5 years of age. Okay, so that means you can implant BAHA only by 5 years of age. So we are back from where we started. Okay, so we can do pinnaplasty at 5 years and then only we can do the canaloplasty. Now the BAHA also I am telling you we can do only at the age of 5 years. Okay, so you see, yes, when we do pinnaplasty, it will take us time to complete the pinnaplasty. Then we do canaloplasty. So normally canaloplasty is done at the age of 7 to 8 years. BAHA you can implant at 5 years. But what will we do before 5 years? Okay, now you see the US FDA, it allows you to do BAHA at the age of 5 years or above. Okay, now if you look at the UK NHS system, it says that if the child is below 5 years, okay, but more than 3 years, then what you can do is you can do a CT scan. Okay, you can do a CT scan, and in the CT scan you can determine the thickness of the skull bone. So if the skull bone is around 3 millimeter thick, you can go ahead and do a BAHA, no problem. Okay, so it gives a little relaxation in this age group of 3 to 5 years. But what will you do before that? Okay, suppose the child of 1 year comes to you, what will you do for this child who is not able to hear from both the ears? Okay, so let's look in this photograph. This is the photograph of the BAHA. This is the screw. Okay, it is implanted behind the site where there will be pinna, and then on this you can attach the bone anchored hearing aid, right? So you can see over here the BAHA that has been implanted in these patients. All right, now suppose the thickness is not 3 millimeter, then what can you do in these patients less than 5 years or less than 3 years? Then you can put in them a soft band hearing aid. Okay, so what is a soft band hearing aid? The soft band hearing aid, the main machinery is same as the BAHA. Okay, you can use the same BAHA, but it is attached to a soft band, and this soft band the child wears. Okay, so it will keep the BAHA machinery near the bone, and the bone will receive the vibration from this machinery directly, and it will be transferred to the inner ear. So patient will have a lot of stimulation, okay, not as much as with the screw, but will still have a lot of stimulation and will be able to hear a lot of things. Okay, and then later on, when the child achieves a thickness of 3 millimeter after 3 years or after 5 years, then you can go ahead and you can implant a screw, and on that screw you can still again use the same machine and apply this machine on the screw, and the patient will start hearing with the BAHA. So because this is not put on the bone, we don't call it as bone anchored hearing aid, we call it as soft band hearing aid, because you are using this hearing aid by applying it on a soft band, right? So this is how we rehabilitate a patient who is having bilateral anosmia with EAC atresia, and he or she needs the hearing. Okay, right, let's come to a term known as meatoplasty. What is meatoplasty over here? Meatoplasty, so we talked about canaloplasty. Okay, I wanted you to differentiate this from meatoplasty. Meatoplasty means widening the meatus. Okay, canaloplasty means making a new canal. Meatoplasty means widening the meatus, widening this EAC. Okay, so this is done usually in the cartilaginous part. This meatoplasty, this is usually done in the cartilaginous part. Okay, it is done after some surgeries such as mastectomy. Okay, so once we do radical or modified radical mastectomy, we do meatoplasty along with it. Okay, right? So that is opening the EAC, especially the cartilaginous part. Okay, so what we do is, there are different ways of doing meatoplasty. Number one is you can give an incision on the concha, you can take out the cartilage, you can rotate the skin inside, and you can make a big meatal opening. Okay, so that is known as meatoplasty. All right, this question has been asked in the exam, in the recent exam, NEET PG January 2020, surgery to widen the cartilaginous part of the EAC, that is known as meatoplasty. Okay, maringoplasty is repair of tympanic membrane. Okay, otoplasty I have just told you to improve the shape of the pinna, and tympanoplasty is repair of middle ear. Okay, that is repair of middle ear. Okay, so this maringoplasty and tympanoplasty we'll be studying in detail later on. All right, so this is meatoplasty, surgery to widen the cartilaginous part of EAC. Okay, right. Let's come to the pinna hematoma. Pinna hematoma is also known as boxer's ear or cauliflower ear. Let's look at the pinna. Let's look at this diagram. So this is a cross section of pinna. We have the medial side and the lateral side. Now we know that this pinna is formed by cartilage. Okay, now on the lateral aspect of the pinna, if you can just feel the skin of the pinna, you will see that this skin of the pinna on the lateral aspect is very tightly adherent to the perichondrium. You see, the skin is adherent to the perichondrium tightly on the lateral aspect. Whereas on the medial aspect, okay, if you look on the medial aspect, you will see that there is loose connective tissue. Okay, there is loose connective tissue. So if you feel the skin of the medial aspect, you will see that this skin is little mobile. You can move that skin on the medial aspect. That's because on the medial aspect there is loose connective tissue. Okay, so now if there is a blunt injury to the pinna, what happens? If there is a blunt injury, because of the force, there is collection of blood between the cartilage and its perichondrium. Okay, we call this as pinna hematoma. All right, so you can see there is a collection of blood between the cartilage and its perichondrium. Now this happens on the lateral aspect, not on the medial aspect, because the medial aspect, this loose connective tissue absorbs a lot of force. This hematoma formation is seen on the lateral aspect of the pinna. Okay, very common in boxing, so it is also known as boxer's ear, also known as pugilistic ear. Pugilists, wrestlers, okay, also known as cauliflower ear. Treatment, the patient comes to you with swelling. Treatment, the treatment is you have to aspirate the blood. Treatment is needle aspiration. Okay, the treatment is needle aspiration. Why I don't want to go and do an incision and drainage? I don't want to do incision drainage because the boxer will again go for the next round of boxing, okay, in the next fight, and again there will be hematoma formation. So there will be multiple scars on the pinna that will give a bad shape. So what we will do is we'll go for needle aspiration, and after needle aspiration you give pressure dressing. Okay, if you will not do needle aspiration, if you don't take out the blood will organize, and you can see over here it will undergo fibrosis, and the patient pinna will be having a deformed shape that is known as cauliflower ear. Okay, so that deformed fibrosed pinna, that is known as cauliflower ear. All right, so treatment is needle aspiration followed by pressure dressing. Also, if you do not aspirate it or the patient does not present to you, the patient may land up in infection in the pinna, that is known as pinna perichondritis. Okay, so now the perichondrium of this pinna is inflamed, pinna perichondritis. Most common causative organism is Pseudomonas, right? Most common causative organism is Pseudomonas. How will this patient present? This patient presents with pain and swelling. On examination, you can see this swelling. It is red, it is hot, it is tender to touch. Okay, treatment. Treatment, you will give antibiotic, it's infection. Okay, now MCQ, ciprofloxacin is the antibiotic of choice because it accumulates in these tissues. So ciprofloxacin is the antibiotic of choice. Okay, other than ciprofloxacin, patients having pain, you can give some analgesics such as NSAIDs. So you can give these analgesics, and other than this, if there is a abscess formation, now you are allowed to do incision and drainage because you don't care for scar, you want to save the pinna. If there is pus, there is abscess, it can cause necrosis of cartilage. Okay, so you will do an incision drainage also if there is abscess formation, right? So this is the patient who presented with pinna perichondritis, and after treatment you can see that the pinna has recovered completely, right? Now let us come to cerumen or wax. So this I have already taught you in the anatomy. What is cerumen? Cerumen is the secretion of ceruminous glands. What is wax? Wax is a mixture of all the secretion: cerumen, sebum, sweat, hairs, dead epitheliums. What is the advantage of wax? It keeps the pH of EAC at 4, and this pH prevents the growth of bacteria and fungi in the EAC. Alright, now sometimes the wax accumulates and blocks the EAC. Okay, so that condition is known as keratosis obturans. Okay, so when the wax grows and completely blocks the EAC, that is known as keratosis obturans. Now you see the wax may be lined by dead epithelial cells all around it. Okay, and that may even lead to expansion and erosion of the bone around it. So much dust material may be accumulated that there is erosion around the material, okay, around this mass of wax and dead epithelium. Okay, so it may even cause the erosion of the bone. Sometimes even the facial nerve, which is in the middle ear and going through the posterior wall of middle ear, that may even be eroded because of keratosis obturans. Okay, now question is, how do you remove impacted wax? Okay, the impacted wax, what we do is we give wax dissolvents, right? So you give wax dissolvents that will dissolve the wax, it will make it semi-solid. Okay, remember, if you try to remove a dry hard wax, it will cause a lot of pain to the patient. So what will you do? You will give some wax dissolvent drops, ear drops. So in 5 days to 7 days time, they make the wax semi-solid, and then you can remove it by microsection. That is the best way to remove a hard impacted wax from the ear. Okay, let's come to the next condition known as acute otitis externa. Acute infection of the EAC. Acute infection of EAC, acute otitis externa. Now the acute otitis externa can be of two types. Which two types? Localized, also known as furunculosis, or diffuse. So what do we mean by localized otitis externa, also known as furunculosis? What's a furuncle? What is a furuncle? Okay, a furuncle is a Staph aureus infection of hair follicle. Staph aureus infection of hair follicle is known as furuncle. Okay, now any furuncle in the EAC is known as localized otitis externa. Why the term localized? Because this is limited in only outer 1/3 of EAC. Okay, why only outer 1/3? We know the answer. Because the hairs are only in the outer 1/3 of EAC, as we discussed in the anatomy. The hairs are not in the inner 2/3. Okay, so localized otitis externa infection, Staph aureus infection in the hair follicles, only in the outer 1/3 of EAC. Right? Okay, so we also call it as furunculosis. Diffuse otitis externa, when the infection is throughout the EAC. Okay, also involving the bony part. Now diffuse otitis externa, most common causative organism is Pseudomonas. Right, how will a patient of acute otitis externa present to us? A patient of this acute otitis externa present to us with pain, severe pain in the ear. Right, the presentation is severe pain in the ear. Okay, so patient comes to you with severe pain. What will you do? You have to examine and make a diagnosis. So how will you examine this patient? So what will you do? You will take your finger, in the index finger, and put it on the tragus and press the tragus. So when you press the tragus, patient has a sharp shooting pain. Okay, he will wince, he will move away, okay, like that. So he may even jump. So much pain will be there. That is known as tragal sign positive. So patient has sharp shooting pain when you press the tragus. So normally if you try and press your tragus, you will not have any pain. But if you press the tragus in this patient, patient will have pain, severe pain. So that is known as tragal sign positive. So that shows patient has acute otitis externa. Sometimes you can even see that the post-oral groove is obliterated. Okay, the post-oral groove is obliterated. So post-oral groove may be obliterated in both. If there is a furuncle on the posterior wall, it will be obliterated. And of course, in case of diffuse otitis externa, when the whole EAC is inflamed, it will be obliterated once again. Right? Okay, treatment. So you have made a diagnosis, treatment. Now, treatment of otitis, acute otitis externa is antibiotics. So antibiotic choice will depend upon the type of bacteria. In furunculosis, we know the bacteria is Staph aureus. Over here, we know the bacteria is Pseudomonas. Alright, so depending upon the type of bacteria, plus you can give painkiller. That means you can give analgesics. Right? You can give NSAIDs. And if the swelling is too much, then you can also give ichthymol glycerin packing. Okay, what is the role of ichthymol glycerin over here? You see, ichthymol is a local antiseptic. Glycerin, on the other hand, is a hygroscopic agent. So it will absorb the water is absorbed, edema goes down, pain goes down. So this is done if the swelling is too much. You put ichthymol glycerin pack in the ear, very gently it is inserted, okay, and within the 2 days when the swelling goes down, this pack automatically comes out. Right? So you put a ichthymol glycerin packing in the ear. Now this condition, acute otitis externa, it is generally seen in hot and humid climate. Hot and humid climate is also known as tropical climate. So this condition is therefore also known as tropical ear. Very common in swimmers. Why? Because you do swimming in summers, and when you do swimming, your ear becomes wet, moist. So hot and humid. Okay, so it is also known as swimmer's ear, tropical ear or swimmer's ear. Right? Okay, let's come to the next condition known as otomycosis. So what is otomycosis? This is fungal infection of the EAC. Fungal infection of EAC. Most common causative fungus is Aspergillus niger. Aspergillus niger. As you can see over here, it forms black color colonies. Okay. Next we have the Aspergillus fumigatus. It forms green color colonies. Green color colonies. Right. And lastly we have the Candida albicans. You can see it forms white cotton-like colonies. So white cottony colonies is seen in Candida albicans. Most common is Aspergillus niger. How will this patient present? This patient presents to us with severe itching in the ear. Severe itching in the ear. Anything else other than itching? Yes. You see, this fungal mass can cause a little bit blocked ear feeling. Okay. So blocked ear, or patient may say decrease in hearing, because the EAC is filled with the fungal mass. Sometimes there can be ear discharge. Right? So patient may present with these findings. Now what do you find on examination? On examination, as I have shown you these photographs, you can see the actual fungal growth. You may even see the color of the fungus, and you can identify the colony, which colony it is, whether it is Aspergillus niger or fumigatus or albicans. Sometimes if the patient presents to you very early, you may not be able to see these colonies, but you see that the tympanic membrane is covered. Okay, so that is known as wet blotting paper or wet newspaper appearance of tympanic membrane. Okay, wet blotting paper or wet newspaper appearance of tympanic membrane. So tympanic membrane is covered by some thin film-like material. So that is the fungus and the discharge of the fungus. Alright, and later on, after a few days, you can even see the colonies of this fungus. Right? Okay, so patient presents to you with ear discharge, with this blocked sensation or decreased hearing. Sometimes there may be mild pain also. What will you do for this patient? What will you do? Remember, most common complaint is itching. Alright, now the patient has a habit of itching. All right, and that is why the automycosis develops, because when you do itching, when you use earbuds, now when you use cotton buds and you do a lot of itching, it creates a lot of micro abrasions, therefore increasing the chances of infection. Plus it also removes the wax, which actually inhibits the growth of fungus and bacteria in the EAC. Okay, so treatment number 1, you request the patient not to use the cotton buds again in the ear. Number 2, the most important treatment, you have to remove all the fungus. If you don't remove the fungus, no other treatment will work. And how will you remove the fungus from the ear? You remember the 90% of fungus is inside the canal. All right, so you do microsuction. The best way to remove anything from the EAC, microsuction, and that is known as oral toilet, cleaning the ear. Oral toilet, you clean the EAC by microsuction, that's known as oral toilet. Okay, and after this you give topical antifungal ear drops. Microsuction, oral toilet by microsuction is the most important step for the treatment of automycosis, right? Okay, now remember, this disease is very common in Singapore. Okay, Singapore, Malaysia, the group of islands, there this disease is very common. So much common that 70% patients who present to a hospital with ear problem have automycosis. It is so much common there. So therefore this disease is also known as Singapore ear. Now some textbooks have mentioned Singapore ear for diffuse otitis externa. Okay, that is wrong. You know, I can say automycosis is a type of diffuse otitis externa. If I say diffuse otitis externa is of two types, bacterial diffuse otitis externa and fungal diffuse otitis externa. So I can say fungal diffuse otitis externa means automycosis. Okay, so Singapore ear, however, is the term specific for the fungal type for automycosis. We do not use this term for the generalized diffuse otitis externa. Okay, normally when we say diffuse otitis externa, we mean the bacterial diffuse otitis externa, which is caused by Pseudomonas. All right, okay, so don't confuse the term. Singapore ear is specific for automycosis. Right, next we come to this question. Automycosis is most commonly caused by, and we know the answer is Aspergillus niger, forms black color colonies. So the next disease that we come to is exostosis, also known as surfer's ear. Now what is this exostosis? These are benign bony growths, overgrowths that are generally seen in surfers. So surfers are people who do surfing in the cold ocean waves. So when you do a lot of surfing in the cold ocean waves, cold water, so these bony growths they develop. Now what are these bony growths? They are a type of body defense mechanism for preventing the water hitting the tympanic membrane and causing a caloric stimulation. Okay, so this is a kind of body adaptation or a body response defense mechanism. These exostoses, they are absolutely benign, and therefore you don't have to do anything for these exostoses unless they start blocking the EAC and patient has either hearing loss, or number 2, there is accumulation of wax behind these exostoses and this wax causes obstruction of the EAC, right? In either of these two scenarios, you will go and surgically remove these exostoses. If they are not blocking the EAC, the wax debris is not accumulating because of these exostoses, then there is nothing that has to be done for this. Okay, right. Next we come to Meningitis bullosa hemorrhagica, also known as bullous meningitis or otitis externa hemorrhagica. Okay, so now what is this disease? First of all, this is an infection by Streptococcus pneumoniae, also known as pneumococcus. Streptococcus pneumoniae or pneumococcus. This is the infection of meningitis. Meningitis means tympanic membrane, inflammation of tympanic membrane. Okay, so this is a Streptococcus infection of tympanic membrane, and this infection leads to formation of bullas on the tympanic membrane. Now what are these bullas? Bullas are the fluid filled lesions. Okay, so you see these bullas over here, these are fluid filled lesions. They're filled with fluid. Okay, now first thing, before I go ahead, first thing, this is a bacterial infection, Streptococcus pneumoniae. It was earlier believed that this is a virus infection. Some also believe that this is a Mycoplasma pneumoniae infection. Okay, that was when we could not identify the bacteria because the fluid is very less. So we could not culture the bacteria. Okay, but around 20-25 years back, we have development of a technique which is known as PCR. So even if there is a very small amount of the fluid, we can pass it through the PCR and we can identify whether it's a virus or a bacteria, and we have been able to identify that it's a bacterial infection, Streptococcus pneumoniae infection. So some books, they still mention virus or mycoplasma. They have not been updated. It's a wrong information. This is a bacterial infection caused by Streptococcus pneumoniae. Okay, now how will the patient present? You see, because of these bullas, patient has a lot of pain, right? So these patients, they present with pain. Okay, now the bulla makes the tympanic membrane thick. All right, so patient has hearing loss. Anything else? You see, because these bullas may burst, so when they burst, there is discharge from the ear, and this discharge is mixed with blood. So it's a blood mixed discharge, therefore the term hemorrhagica. Okay, so meningitis bullosa hemorrhagica, also known as bullous meningitis. It was earlier known as otitis externa hemorrhagica. That is a wrong term. It is not actually on the otitis externa. It is not otitis externa because it is not on the external ear. It is in the tympanic membrane. So it is meningitis bullosa hemorrhagica. That's a better term for this thing. Okay, now treatment. You see, on examination, you can see these bullas, you can identify this disease very easily. Treatment is by steroid plus antibiotic ear drop. The antibiotic takes care of the bacterial infection, the steroid decreases the inflammation, and problem is solved. Okay, so antibiotic steroid ear drops. Now, during the healing phase, these bullas, when they heal, they give a sago grain appearance to the tympanic membrane. So the sago grain appearance is seen in the healing phase of meningitis bullosa hemorrhagica. Right? Okay, lastly we come to the disease known as malignant otitis externa. Now the first thing over here, the term malignant. This term malignant, this is a misnomer. Okay, this term malignant is a misnomer. This disease, malignant otitis externa, it is not a malignancy. It is an infection. Okay, it's a rapidly spreading infection. Okay, by Pseudomonas. So now, why the infection is rapidly spreading? Because the patient is immunocompromised patient. So rapidly spreading infection by Pseudomonas in a immunocompromised patient. Okay, such as HIV/AIDS patient, diabetes mellitus patients with uncontrolled sugar, okay, leukemia, lymphoma patients. So all these are immunocompromised patients. Okay, now, first thing, what happens in a malignancy? In a malignancy, the cells, they rapidly divide and they invade the surrounding tissue and they destroy the surrounding tissue. So there's a lot of tissue destruction. What happens in malignant otitis externa? You see, the Pseudomonas invades the surrounding tissue, and because the patient is immunocompromised, so invasion is very rapid and it destroys the surrounding tissue. So there's a lot of tissue destruction. Okay, it looks like a malignancy, but it is actually not a malignancy, it's an infection. All right, how will the patient start? How will the patient present? The patient presents with pain. Right, anything else? The patient will have discharge, ear discharge, a greenish black color ear discharge. Right? On examination, inside this, you can also see that there is some bare bone, naked bone, because the tissue is destroyed. And on this bone, you can even see the granulation tissue. Okay, you can see the granulation tissue on the bone inside the EAC. That's because of the destruction. Okay, right. Now remember, from this EAC, the infection can go to the skull base. If the infection goes and involves the skull base, it is known as lateral skull base osteomyelitis. Lateral skull base osteomyelitis. Okay. Now first thing, how can the infection go from EAC to skull base? It goes through fissures. There are 2 to 4 fissures. These are known as fissures of Santorini. Okay. So we have 2 to 4 fissures in the anterior cartilaginous part. Anterior cartilaginous wall of EAC, we have the 2 to 4 fissures known as fissures of Santorini. From here, the infection goes to the skull base. Okay, right? Now, similar to these fissures, we also have a foramen that is known as foramen of Hashka. This foramen is present in the floor of bony EAC. Okay, and this foramen, it closes by 4 years of age. So by 4 years of age, this foramen closes down. Right? Okay. Now, if this foramen is present, it can transfer the infection to parotid gland or temporomandibular joint. So you see, if after 4 years this foramen is present, okay, so that's a defect, or below 4 years of age, it can transfer the infection to parotid gland or temporomandibular joint. Right? Okay. Now please remember over here the term S. S for skull base, S for Santorini, and S for soft cartilaginous part. So fissures of Santorini in the cartilaginous part, soft part. Okay, and they transfer the infection from the EAC to the skull base. H. H for Hashka, H for hard. Okay, so foramen of Hashka is seen in the hard part, the bony EAC, right? And it transfers the infection to joint, temporomandibular joint. Joint is also a hard part, or the parotid gland. Clear? Okay, now some books have mentioned this as wrong. Remember, this disease, malignant otitis externa, is seen generally in immunocompromised patient. Immunocompromised patient we tend to see are generally the old age patients. In them, we don't have foramen of Hashka. In most of those cases, the infection spreads only through the fissures of Santorini. Okay, so there should not be any confusion in this. The malignant otitis externa or the lateral skull base osteomyelitis happens because of spread of infection through the fissures of Santorini. Okay, now if the infection goes to the skull base, what will happen? It can cause multiple cranial nerve palsies. Patient can have multiple cranial nerve palsy. Most common cranial nerve palsy is the facial nerve, 7th nerve. Most common cranial nerve palsy, facial nerve palsy. Right? Okay. Now, how will you diagnose this condition? The patient comes to you with facial palsy, ear discharge. How will you diagnose this condition? Number one, you can do a CT scan. Now the CT scan will show you bone destruction. Look over here. All this bone has been destroyed. You can compare from this side. All this bone has been destroyed. But this bony destruction is seen in late stages of disease, when the destruction has already taken place. Now, if you want to diagnose this disease in the early stages, what you can do is, you can do a bone scan, technetium 99M scan. That is known as bone scan. Okay. Now, what is the advantage? You see, even if the bone is inflamed, this technetium, it is absorbed by osteoclast. Okay. The osteoclasts, they become active if the bony inflammation is there, and they start causing bone resorption. So if the active osteoclasts are there, they will absorb the technetium. So there is accumulation of technetium, and this we can see in the bone scan. It will tell us whether the bone is inflamed or not. Okay, so bone scan or the technetium 99M scan, this is the diagnostic investigation of choice. It will confirm our diagnosis of malignant otitis externa. Okay, now remember, we can also do SPECT scan. Okay, single positron emission computed tomography. So what we can do is, we can do a three-dimensional study. Instead of doing a single dimensional study, we can do a three-dimensional study, okay, and we can see a three-dimensional view of this bony inflammation. We can also superimpose this on a normal CT scan film to further enhance our area for the inflammation, our more understanding of this area of inflammation. Okay, but however, the bone scan helps us make a diagnosis, a clear-cut diagnosis. We rarely need to do a SPECT scan or a SPECT CT scan. Okay, right. Now, what treatment will we do for this patient? The treatment, it's a bacterial infection by Pseudomonas. So treatment is antibiotics. Okay, we give IV antibiotics. Now, which IV antibiotic is the drug of choice? Answer is ciprofloxacin. Okay, this is still the drug of choice. Yes, we have some specific anti-pseudomonal antibiotics also. Okay, we also have some anti-pseudomonal antibiotics such as ceftazidime, okay, cefoperazone. Cefoperazone, remember, is given with salbactam. Okay, we have meropenem, imipenem. This is the carbapenem group. We also have drugs such as piperacillin. Piperacillin is also given with tazobactam. So we have these antibiotics, but still the drug of choice is ciprofloxacin. That's because it has a very high tissue concentration in this area. Okay, this is still the drug of choice despite specific anti-pseudomonal antibiotics. Okay, now let's say we have given a patient all these antibiotics or a combination of these antibiotics, and we want to know what is the progress of this patient. We want to know how much inflammation is still left inside, how much disease is still there, whether the patient is responding to our antibiotics or not. So we want to scan again. Can we do a bone scan again? No, we cannot. Why? You see, the bone scan is absorbed by this technetium 99. It is absorbed by osteoclasts. These osteoclasts, they live for approximately 9 months. The T half is 9 months. Okay, that means this scan will be positive for next 9 months to 12 months time. 1 year time, it will be remain positive. So if this is positive once, you cannot repeat the bone scan again because it will remain positive for next 9 months to 1 year time. Okay, so you cannot use this for prognosis. So what we do for prognosis to find out the improvement, okay, whether the patient is responding to treatment or not, we do a gallium scan, GA67. Now the gallium is absorbed by the leukocytes. And the leukocytes, they increase in concentration if there is inflammation. Okay, right? And their T half is 3 to 4 days. So that means you can repeat this scan every 1 week, right? And you can see whether the inflammation is increasing or decreasing, right? So gallium scan, this is the prognostic investigation of choice. Now the last question, why don't we use gallium scan as a diagnostic investigation? You see, gallium scan is using leukocytes. Okay, the gallium is absorbed in leukocytes. Leukocytes will be increased in any inflammation. Whether it is a soft tissue inflammation or a bony inflammation doesn't make a difference. Even in soft tissue inflammation, they will be increased. Okay, so that means this is a non-specific scan. Whereas when we did the technetium scan, that will show an increase only when the bone is inflamed. So that was a specific scan. Okay, technetium 99M is a specific bone scan. You need it for diagnosing that there is a bony inflammation. Gallium GA67 scan is a non-specific scan. You are using this to see just how much inflammation is left. Okay, so therefore it is the prognostic investigation of choice.